through the process where the anticipated identification of those who may have a problem and who might benefit from further investigation and treatment. So, and also WHO defines few guidelines for what all should we do screening for. So the condition should be an important public health problem. There should be an accepted treatment. Facilities for diagnosis and treatment should be available. There should be a suitable test. It should be acceptable to the problem. The natural history of the disease should be adequately understood so that we can intervene. There should be agreed policies. The cost should be good enough so that it doesn't offset the balance of screening. And also case finding should be a continuous process, not just an ad hoc thing. And these make even more sense when you're talking about childhood eye disease. But looking at some of these definitions, childhood eye screening all programs may not fall into the precise definition of screening, because in a lot of these cases the disease or the pathology or the condition has already occurred. We're just trying to detect it early and try to intervene. So we can actually imply case finding or case detection when we look at these terms. So what all can we screen for children? So basically based on age groups, we can screen children for a lot of diseases. In fact, premature infants, we can definitely screen them for retinopathy of prematurity. Perinatal period for congenital cataracts, other anterior segment pathologies, glaucoma. Preschool children can be screened for amblyopia, strabismus, and anisometropia, other uncorrected refractive errors. And also school-grade children can be looked at, higher uncorrected refractive errors that are causing blurry vision and others. Also, incidental detection of congenital anomalies can happen at any level. But why screen for childhood visual impairment? We will be hearing from other authors regarding the magnitude of the disease, so I'm not giving those numbers here. Dr. Taranum will give you those numbers, which are pretty alarming. But we know that Vision 2020 does consider it as an important public health issue. Children, in terms of blind years, childhood blindness is the second largest cause of disability life years, just after cataract, which is more in numbers. So we know that a child with blindness has to live a lot of years. So that blind year component is much more than adults. Also, it's not about just the health of the child. The vision of the child is also linked to the overall development of not just the child, but also has an impact on the overall society. In terms of the development goals, it affects the under 5 years child survival rate. We know that children with significant visual impairment have considerably reduced longevity. Education, good vision, perfect eyesight is definitely a contributor to good education. And also in terms of overall intellectual development, employability, good visual acuity is also essential. So it goes a long way in poverty elevation. So looking at this, childhood blindness definitely qualifies for putting efforts in early detection and providing good treatment modalities and adequate management overall. But what are the challenges? It's not exactly as the adult screening, because there's definitely low prevalence relative to adult programs. So when we look at an adult blindness program, the prevalence thumb rule may be 1% of the population, whereas in children it is much lower. It's sometimes as low as 0.8 in per thousand. So you need to screen a very large number if you go the conventional method of screening all children. Lack of awareness definitely is an issue, because in most of the areas, parents are not aware of what the possible issues may be. And not just the parents, sometimes the healthcare providers, be it pediatricians, be it the primary health physicians, even sometimes general ophthalmologists are usually not fully aware of what are the conditions that a child may have. So consequently, what all should be done. Also, the skill required to screen children is definitely more than that required for screening just refractive errors in adults or even a simple cataract. So you need highly skilled manpower, which definitely is a limitation. There is a social stigma attached to children with blindness or any ocular anomaly as such. So a lot of these may not be forthcoming to bring the child to a suitable location where he or she can be screened, particularly the female child who, if is blind or has an ocular deformity, would rather be kept isolated and not brought forward than be detected early. Lack of service provider for providing affordable treatment, because although tertiary care in India has bloomed a lot and pediatric ophthalmology is one of the specialties that's taking leaps and bounds, but having a service which is affordable and accessible to communities which may not be essentially affording it is challenge. So what is the ideal case finding methodology for childhood blindness? As for any other, low cost and high yield. It needs to be cost effective. So per unit cost of acquisition of a child with visual impairment, that can be modified, or in which we can actually help them. It's not just detecting cases, it should be detecting cases who actually can be helped in some way or the other. The methodology should identify all cases in the region. It should not be limited to a very isolated population. Community involvement has to be there because, as I said, in children, the parent is the care provider. The parent is the one who takes decisions. So the community has to be involved. There has to be a component of health awareness because, as we saw earlier, awareness is one of the lacuna. It needs to be linked to service provider because just identifying children without having a service provider who can help them is not a good idea. It needs to be integrated with existing health systems, or at least have a potential for it. A child is not just two pairs of eyes. There is a whole body which is developing. So there may be other pathologies, particularly when we're looking at things like retinopathy of prematurity or congenital cataract. There may be other things that the child may need help for. So as far as possible, we should try to link it with an existing health system wherein the child can get those health benefits, including nutrition and hygiene also. And in one way or the other, the program needs to be self-sustainable, so that there is no need for doing continuous same level of screening throughout till infinity. Of course, the screening level should reduce, and it should encourage community referrals. Unfortunately, getting this whole mix is not possible, but we should, as far as possible, consider that most of these are available in your screening programs. There are various case finding methodologies available, and a lot of good ones have been done. Community-based screening, the house-to-house model is there. There are blind school screening programs, community-based rehabilitation programs using as screening, key informant methods, and also some multi-pronged programs which use multiple methodologies to do screening. So I'll just try to give a very brief of what these techniques are and what are their merits and demerits. The choice of the methodology will depend on a lot of factors. The purpose of screening, whether we're doing a generic screening or is there disease-specific screening, like retinopathy of prematurity or a particular anomaly. Are we looking at particular age, like conventionally we say 0 to 5 and 5 to 6 to 15. Organizational capacity or resources, whether the organization has the capacity to handle that. Geographic factors will have an influence. Demography of the population, whether it's a migratory population like urban slums or it's a village population. Service availability and existing health systems to provide basic pediatric care also. Community-based screening is probably the simplest but still the most comprehensive one. So the method there is you select a geography, enumerate the children of the region, so you identify where are the children. You do home visits for preliminary screening with trained teams. Screening camps can be done for final diagnosis, and all the children who are diagnosed or even suspected of having pathologies can then be referred to the hospital for further diagnosis and treatment if needed. So an example of this was done with Dr. Shroff Charity Hospital in a district called Alwar in Rajasthan in the period 2000-2003, where around 1,54,000 children were screened, out of which almost 2% of them were given spectacles and around 1% were provided with surgeries including cataracts and squints. Also 23% required medical treatment, which was more than just giving glasses and all. So we see that the yield is definitely much higher for medical treatment, but for surgery and spectacles it was much lower. But the advantage is that we were covering the whole population, and so the definite merits was that it covers the entire population, but there is higher possibility of identifying all cases provided the screening is extensive enough. The merits are definitely there is low yield. There is definitely is very expensive because you need to go door to door in the whole community. It needs trained manpower in the field, which is not very easy to find. There are high dropout rates in the community because even when you identify them and you tell them to come to the hospital for treatment, not all of them will come. And it's been the experience that you need a lot of convincing to get them even to come to the hospital for a treatment. Community engagement is minimal because you're just going as an outsider, you're doing a screening, coming back, there is no remnant awareness or community linkage there. And of course, it's highly dependent on external support, so it's not sustainable. Blind school surveys are another technique to specifically identify children who have very extensive visual problems. In this, the process is that you try to enlist the schools for the blind in the region, and it's been an experience that a lot of children in these blind schools are actually suffering from diseases which can be treated and they can be rehabilitated quite a lot. But we need to contact the schools to get the data and visit the school with a screening team which needs to have a pediatric ophthalmologist, an optometrist, preferably a low vision specialist and rehabilitation counselor, so that we are able to provide some basic care on the site. All children need to be identified in detail as far as possible, and children who have pathologies can be then referred. If children require low vision assessment or surgery, they can then be counseled through their parents to be sent to the right centers. The merits are a large number of children with visual impairment can be screened at one time because they're in a captive audience. It needs a single team because you're going from blind school to blind school. It is relatively less expensive than the community-based screening approach. But the demerits are because of the social and socio-economic conditions. Children, especially younger children and girls, will be under-screened in this because they are the ones who are not available in the blind schools. Logistics are often difficult because you need to travel to schools and getting them arranged is difficult. There is sometimes resistance from family and organizations to either go in for screening or referring them for treatment. The intervention is delayed because the child at that time has crossed that critical period, so an intervention will have a suboptimal effect. And also, as there is no family involvement, there is hardly any health awareness, and it's again non-sustainable. Community-based rehabilitation programs are a novel idea wherein these programs are essentially targeting people with disabilities, and a community-based rehabilitation approach is used. But these programs can often be used to identify children with disabilities, particularly visual disabilities. It could be a component of an ongoing community-based rehabilitation activity, so logistics are definitely shared. Some community engagement can be planned, so acceptance is slightly better, but the demerits are usually limited to geographic area, so it does not cover the whole area. Social stigma, as I said, is a problem. Community-based workers may not be trained enough, so the level of screening may not be very good. There is definitely a delayed presentation and the disadvantage for that. Key informant methods again is a novel idea. It's been in this line, at least in eye care, has been used very recently. It was used in other disability sectors, in leprosy, for a very long time. It's an effective community-based approach wherein you identify key informants within the population who are enlightened or members in the community who want to work towards the development of the community, and these people are then trained in a very short span to identify what are the basic diseases in children. They are not given clinical tests, but they are usually trained on appearances, on what the child will experience and all that. So they could be either health workers, school teachers, NGOs, government staff, religious leaders, anyone who is in the community and is interacting with the people who can potentially say that, okay, that child in the village does not seem to have healthy eyes. And they can then do a mapping of the community. They can refer these people, the children, to a recognized linked facility who can then treat them. The advantage definitely is there is a lot of community engagement. You are trying to identify people who are significant members of the community. They are actively involved. They can screen large regions in less time because you can have multiple key informants. So one informant can easily screen one whole village during his period. And there is definitely long-term sustainability because once these people are trained, oriented, they are there in the community. They'll keep on referring you patients. So they're almost like your ambassadors in the community once they have been oriented. Disadvantage definitely is that it depends on the dedication of the key informant. If in the beginning they were encouraged, but later on they realize that it's a lot of burden on their regular day-to-day life, they may not be as excited about it later. The training definitely is required, and sometimes they may need refresher trainings. There definitely is a high incidence of false positives because they are not fully trained clinicians or clinically oriented people. It needs detailed social mapping of the region, which usually is not the purview of a clinical oriented organization. So you need help from a social organization to do this social mapping and help you, which will be the best informants as such. These are the single strategies in which one approach was used to identify. Then there are other strategies in which multiple activities are done to improve the screening. These are multi-pronged screening programs. I'm sharing with you two examples that I've been associated with. The first one is an awareness-linked screening program, because the challenge was that lack of awareness and local misconception leads to childhood blindness. And keep on doing screening, but if you don't make the community aware, you will still have to do screening long term. So the components of this multi-pronged strategy are targeted health awareness, community engagement actively, active screening, and service provision. So it has targeted eye health awareness, which has IC material, which are scientifically developed and tested locally to give the right impact. There is extensive community engagement of all stakeholders, parents, health workers, community leaders, teachers, to motivate them and tell them about the diseases. And these are the findings. Over 31,000 children were screened and a huge amount of surgeries were done. Plus, on the left-hand side are the values that have been created. So you've made people aware, individuals have been trained, health workers have been trained, and these will be in the community, so they'll keep on doing these activities later on also, preferably into a sustainable model. The other one is in South India. It's been done through Shankara Institute in collaboration with Sight Savers. The components of that are extensive IC, field surveys, and advocacy. They have 3 programs in which they do extensive advocacy, active school screening, and collaboration with ICDS system and Anganwadis to do the screening of the children. They do opportunistic screening through schools, ICDS systems, maternity homes, and other shelters where captive population is there. Plus, there is door-to-door screening in the area and surrounding the project, not just to do screening but also to create awareness of the program so that people can actually come down. They do awareness and education of the children and parents, and also children who are visually impaired or blind are also sent to rehabilitation services and linked to inclusive education programs. So the children in this are screened. The ones who have a normal vision are sent out with awareness messages. Children who have some anomaly are then taken into the system. If a refraction is needed, they are given refractive correction, or they are referred to the base hospital for various things like diagnostics, complex refraction, surgeries, and also there are adequate linkages with inclusive education and vocational training programs for children with unavoidable or untreatable visual impairment, so that it completes the loop. It's much more than just vision screening. A comprehensive examination is done, which includes vision screening, color vision detection, squint or cataract screening, frame selection, and appropriate plastic glasses are provided also. As in the earlier program, extensive IC is done through interactive methods like animations, posters, workshop with doctors, training of teachers and all that. Plus, there is also an active component of advocacy, both with the policymakers as well as in the community, trying to make them aware about the problem so that the community engagement is quite a lot. And these are the figures that have been seen. Around 156,000 children were screened, out of which around 719 surgeries were performed. Some advanced treatments like oncology treatment were also done, and rehabilitation was given to 47 children. So in conclusion, what we're looking at is, with these multi-pronged strategies, the need for active screening should be transformed into a positive health-seeking behavior, where these children can then be, there's no need to do active screening. With the community aware, the awareness of the policymakers, it should lead to self-reporting and community referrals, which in turn will make these programs much more sustainable and much more effective. So the take-home messages for childhood screening are: the activities need to be planned as per local requirement, both the provider as well as the community. Health promotion is an essential component. You can't just do with screening, you have to have a component of health promotion. Community engagement of all stakeholders, linking with service providers, and long-term sustainability need to be in question. Thank you.
Thank you, Dr. Sandeep.